Hello, this is Team Two's presentation of standardized medication discharge teaching to drive readmission reduction. This paper's focus was on high blood pressure management, and our desire was to decrease the occurrence of readmissions over a course of 30 days.
Project took place at Capstone Hospital and focused on improving medication discharge education using the teach-back method. The project addressed a common issue where discharges happened quickly and key teaching and documentation steps were missed. The intervention used a standardized nurse checklist built directly into the workflow. Over a 10-week period, nurses used this checklist with every discharge, and compliance was measured using weekly chart audits. The goal was to create a reliable process to support consistent medication education, promote safety, and reduce preventable readmission risk. The project followed the Johns Hopkins PET model. The project was evidence-based and systematically translated into daily nursing practice that promoted patient understanding and supported safe transitions of care. Significance of the project. Medication-related readmissions are a major concern and contribute to more than 125,000 preventable deaths each year and over $528 billion in the United States in healthcare costs. Hospitals experience a significant impact like financial penalties tied to quality performance measures. Internally, Capstone Hospital showed a 17% 30-day readmission rate, with 22% of these readmissions directly associated with medication compliance. Nursing discharge audits revealed that 1 in 3 patients reported confusion about their medication instructions at discharge. This project targeted frontline nursing staff where improvements would be immediate and sustainable. Standardizing the nursing checklist strengthens workflow reliability, improves accountability, and ensures patients receive consistent medication education. This project supported quality improvement goals by enhancing patient safety and reinforces the nurse's role in closing care gaps that impact patient outcomes and organizational performance.
While the problem is clear, the organization is currently showing resistance to change, which is uncommon to healthcare, especially when new projects are perceived as extra work or costly. A core goal of this analysis is to strategically address this resistance and ensure the new change project is successfully implemented. We use the power interest matrix to map who has the most influence and who has the highest investment in patient success. The stakeholder analysis revealed that nursing leadership and the quality department hold the most organizational influence. We must work with them to secure approval and align the project with organizational goals. Conversely, key groups with the highest interest in the success, those invested, include pharmacists, case managers, and home health nurses. Their direct involvement and enthusiasm are critical for execution as they are front lines of patient adherence. Patient and family are also categorized as high power and high interest. The outcomes directly depend on their adherence and follow-up. This mapping informs our strategy. Sipes explains that project success depends on fitting the design to the culture and context of the organization. We must use different engagement tactics for each group. To ensure buy-in, we frame the project as a joint effort rooted in the advanced nursing practice, competencies, or quality and person-focused care, and not as a mandate. Our communication will be adapted using brief huddles, short email, one-to-one leader touchpoints to overcome resistance and explain the project benefits clearly and consistently. Our 10-week project timeline is structured into 4 strategic phases. We begin with phase 1, mobilization in weeks 1 through 3. During this critical startup period, our focus is on securing IRB approval, gathering baseline hospital data on readmission rates, and training the nursing staff on the new teach-back strategies. Moving to phase 2, implementation. During week 4 through week 6, we officially launch education protocol. Week 5 is a key milestone where we conduct fidelity checks and our first PDSA cycle, plan, do, study, act, allowing us to refine the process in real time before our formal midpoint evaluation in week 6. In phase 3, spanning week 7 and 8, we focus on sustaining the intervention and monitoring 30-day readmission trends. Finally, we conclude with phase 4 in weeks 9 and 10, where we analyze the final data and present our findings and recommendation to the stakeholders. This is our Gantt chart timeline.
Risk management is central to reducing preventable readmissions related to medication noncompliance. CMS financial penalties create strong organizational urgency to address these risks. Based on the project's scoring matrix, the highest impact risks include frontline staff resistance, limited time during discharge, and inconsistent medication reconciliation. Evidence shows these factors commonly undermine sustainability and adoption. Additional risks relate to low patient health literacy and weak post-discharge follow-up, which the WHO identifies as major contributors to medication errors. To control these risks, the project uses unit champions, audit and feedback loops, simplified EHR workflows, mandatory teachback, and conditional pharmacist involvement. All risks responses follow the TAME framework to ensure threats are systematically mitigated or avoided. The SWOT analysis shows a tension between strong organizational foundations and several staff-related weaknesses. Strengths include robust baseline data, strong interdisciplinary coordination, and adequate staff support. However, weaknesses such as low compliance and inconsistent reporting require targeted strategies to maintain fidelity. Opportunities include policy alignment with sister facilities and improved collaboration with community clinicians. Threats include new education requirements and resistance from outpatient providers, which can lead to disrupt the continuity of care. The SWOT analysis findings were used to prioritize risks and tailor mitigation strategies, helping ensure the project remains sustainable and aligned with broader system needs. The M3 systems framework illustrates how this project functions across micro, meso, and macro levels. At the micro level, patients, caregivers, and frontline nurses directly influence medication understanding, with the WHO emphasizing the importance of clear teaching and teachback. The meso level includes managers, educators, pharmacists, and interdisciplinary teams to coordinate workflows and act as change agents, though they often face barriers such as staffing shortages. At the micro level, CMS readmission policies create a financial and strategic pressure for organizations to reduce readmissions. Research shows that projects are most sustainable when strategies are aligned across all 3 levels. Advanced practice nurses play a key coordinating role in linking project management with clinical leadership to maintain this alignment. Lowen's model of planned change provides a structured framework to guide the implementation and evaluation of this medication adherence intervention. According to Stans and colleagues, the unfreezing, change, and freezing steps help organize, adopt, and sustain new practices. At Capstone Hospital, this process aligns well with Johns Hopkins' model for planning and evaluation. This would be our change theory. During the unfreezing phase, the team will collect baseline data and identify key barriers during using interdisciplinary input, which is consistent with recommendations from Malik and Fennell Overholt. The change phase includes applying evidence-based strategies such as structured discharge counseling as supported by Carol, and digital medication reminder tools shown to improve engagement. In the refreezing phase, these successful strategies are incorporated into routine workflows to ensure long-term adoption as described by Stans. Evidence from Pew and Sol confirms that clear medication teaching and follow-up significantly reduce hospital readmissions, reinforcing the importance of this model.
The budget for this project used mostly in-kind resources, so that left the budget with minimal new expenses. Nursing staff completed teach-back education as part of their regular discharge processes, so that no additional salary expenses were incurred. Preceptor and administrative salaries were also provided in kind as part of routine clinical education and quality improvement activities. Capstone's resources, including training space, computers, EHR access, medication adherence tracking software, electricity, and so forth, did not require additional funding. The only direct cost was for specialized printing of project materials and laminated teach-back job aids at a cost of $300 for the 10-week period, and refreshments at a cost of $50. Total revenue for this project was about $3,100, with a cost avoidance showing a net balance of $360. This amount includes the 6.4% offset cost of one readmission.
Standardized medication discharge teaching, which reduces readmissions. The dissemination findings that we found were critical to sustain the reduction of those 30-day readmissions and promote evidence-based medication adherence. Our team had designed that target dissemination strategy that helps share data-driven results with key stakeholders. This helps to standardize that checklist, and it becomes an integral part of that discharge protocol establishment. So we ended up going with the primary goal of the internal dissemination, which optimized all those findings and ensured current and future staff buy-ins. This also allows for the project team to present the findings at a unit-based council and patient safety committee within the organization. This helps to show all the initiatives and the quality improvements that are going to be happening. We also wanted to seek our findings at a local, regional, and national level, which allows for a broader practice. It ended up showing that our venues provided an ideal platform that discussed over 980 estimated cost avoidance per patient with this interaction.
This policy brief supports advocacy efforts that directly address medication-related readmissions and CMS financial penalties. Strengthening organizational policy helps ensure consistent adherence to best practices. Standardizing teach-back and health literacy-based education aligns with WHO recommendations, and recent literature showing that education alone is often insufficient without reinforcement. Pharmacist-supported reconciliation should become mandatory for high-risk discharges, as evidence shows it reduces medication errors and readmissions. The policy should also require improved communication with community providers and pharmacies, which Crashaw and McClearly identify as essential for safe transitions. Finally, sustained implementation depends on structured training, audit and feedback, and leadership support. An area highlighted by both implementation science research and project management frameworks, described by Zurinsky and Sipes. Overall, these policy actions promote patient safety, reduce readmissions, and strengthen continuity of care.
With regards to additional background, we ended up having a high occurrence of noncompliance with the medication adherence, and the focus of our project was to cut down on those preventable readmissions with the older adults because we wanted to establish a better teaching strategy with earlier discharge planning at admission. Essentially, we wanted to engage in effective community partnerships that address the public health needs like medication adherence, reducing readmissions, with that core competency that we were trying to do a checkoff with. We established a community advisory council. By doing that, joint advisory representatives from the local pharmacies, home health agencies, community clinics, advocates that ensured those patient accountabilities. This was able to give us the necessary community feedback, which gave us better overcoming the external resistance that we were having when the patients ended up going home. Also, we ended up wanting to do equitable resource allocations with our community resource mapping, advocating for the telehealth and mobile clinics, which gave better outcomes and thorough education. As Capstone Hospital continues to have the commitment to reduce the noncompliance medication adherence within the facility, this allows to have a reduction in approximately $980 of cost avoidance. In addition to that, we've developed this new policy that can also be standardized and progress out towards multiple other facilities, and this allows for continued improvement opportunities. We're going to have to continue as a unit to reevaluate and update this process as new medication standards change, revisions with any evidence-based practice, as well as new providers that are wanting to transition to a different methodology of care.
These alternatives highlight several practical ways the organization can strengthen medication adherence and lower readmissions. One option is to reinforce discharge teaching using the teach back approach, which helps confirm that the patients understand what they are supposed to do once they leave the hospital. Another option is adding pharmacist-led reviews to reduce issue related to medication costs, because many patients fail to take their prescriptions simply because they cannot afford them. Follow-up calls and digital reminders are also helpful because they provide patients with extra support at home and have been shown to reduce avoidable readmissions. Staff could also complete short mobile learning modules to stay updated on discharge processes, which supports long-term consistency. Together, these alternatives give the organization different paths to improving medication adherence based on the needs of their patient population. The recommendations focus on strategies that the organization can put into practice right away to improve medication safety and reduce readmissions. Using a standardized discharge checklist creates a consistent process and limits missteps during patient teaching. Requiring teach back during every discharge strengthens patient understanding and aligns with national safety expectations. Scheduling follow-up phone calls soon after discharge is another recommendation supported by strong evidence showing fewer 30-day readmissions when patients receive timely support. Pharmacy cost reviews should also be built into the workflow because financial barriers are a major reason patients do not take their medications correctly. Leadership involvement is necessary for these changes to last, especially since readiness for change depends heavily on leadership support and clear communication. Together, these recommendations provide a realistic and evidence-based foundation for developing an organization-wide policy.